Hi, everyone. Good morning. First of all, it's great to be here. Nothing excites me more than having a chance to talk with super smart people in an audience of super smart people. So I hope I'm up to the task. And Daisy, let's start with you. I want to get as much in because we only have 25 minutes. You're an investing partner at Andreessen Horowitz. You focus on healthcare technology. So can you set the stage for us, Daisy, about some of the ways AI is being used today and the promise it really holds for the healthcare industry? Because from my understanding, it is going to be truly transformative, perhaps more in that industry than any other.
Of course. And first, Northwell, thank you for having me. Katie, thank you for all you do for the cancer and oncology community, from sharing your and your late husband's stories to raise awareness, to stand up to cancer, and the Jay Monahan Center, and so much more. We are all so grateful.
Oh, that's so nice. We have a few more minutes to talk about that. Thank you, Daisy.
Good job. Good job.
From my perspective, this is an incredibly exciting moment in healthcare due to AI, and I know I am going to be one of the optimists in the room today, but we spend our days meeting with promising healthcare technology companies, and we are already seeing AI take on a lot of the minutia of healthcare, the things that plague patients and providers, like scheduling appointments and fighting erroneous medical bills and doing prior authorization for medication. But the more exciting thing is what we're seeing in the clinical world. AI can already pass a medical licensing exam to become a doctor. AI can read an X-ray as well as a radiologist. So very soon, every doctor is going to have a co-pilot taking a lot of the lower level work off their plate and allowing them to focus on the most impactful issues. AI is going to play a key role in diagnosing cancer and other disease, as Andy will talk about. And AI is going to drive drug discovery and think up new therapeutics that have not been dreamed up by human scientists yet. So, Katie, the future is bright.
That's really exciting. And Andy, actually, that's a good segue to your work. Are you the CEO of Paige?
Yep.
And that's using AI to really transform cancer diagnosis. Yep. As the screen queen, I'm super excited about that. Yeah. Can you tell us a little bit more about the technology you're using and how?
Yeah, sure. Thank you, Katie. Again, thanks so much for everything and for the invitation to be here. Dr. Dowling this morning talked about two areas AI is really benefiting today, and that's in making better diagnosis and reducing human error. And that's where we focus. And we work in this area of cancer that's really not very well known. The reality is, and in much respect to my radiologist colleagues in the audience, nobody really has a clinical case of cancer until a pathologist says you do.
Right.
And those pathologists are the ones that are looking at the tissue under a microscope. Unfortunately, that process has not changed much in about 100 years, right? This tissue gets cut thin, it gets fixed, it gets stained, it gets put on a slide, and the only thing you can get out of that piece of glass is what that pathologist knows, their expertise and their training. And ultimately, we think about a world where, unfortunately, these are human beings, right? They make mistakes. There was an article in the Wall Street Journal about 3 or 4 weeks ago that talked about maybe up to 20% of cancers are misdiagnosed or misclassified, which has a huge impact on the work that Dr. Barakat does and the oncologists who are trying to treat these patients, right? You have to start with the right diagnosis and get it right the first time. And so what we endeavor to do is to take these glass slides, these analog instruments, and digitize them. And once they're digital, you're able to unlock this huge world of machine learning and AI and all of the things that come with it.
But that's challenging too, isn't it, in terms of, Andy, providing the infrastructure for all that data and how expensive it is. I know that's one of the big challenges.
It is. That's exactly right. I mean, every slide can be up to 2 gigabytes worth of data. And if you think probably in this country, 30 or 40 million slides are produced every year, maybe more than that. And so it's a huge amount of data to sort of deal with. We work with Microsoft as an example to help with that data infrastructure piece, right? How can you store these images in the cloud, but also use the power of Microsoft to be able to have the ability to query these slides and these images and get the answers that you're looking for?
I was telling Andy before we came on about this MIT doctor who is a breast cancer patient herself, working with the data scientists. I don't know if you all know about this, but it's fascinating because she's using AI to not only for diagnosis, but to actually use it in a predictive way, that they can look at a scan or a collection of data, as, when they look at the scan, have the benefit of a collection of data and be able to predict if someone will get breast cancer in the next 5 years. Do you see that happening in your work as well?
I do, and I think the future, if I'm talking 5 or 10 years into the future here, is all what they call multimodal, right? So we think about genomic information, clinical lab data, your screening, your clinical notes, your H&P. Generally, you take all of that data and you can build models that then have predictive values to them and really start to parse out upstream the population health side of this, which is who in this population might be at a higher risk for breast cancer, as an example, or prostate cancer, or whatever the case may be. But then downstream, if you do get that mammogram, you can have better predictive outcomes. And then also think about today, we can start to predict which patients are going to recur, just directly off the slide, but also which patients might benefit from a specific type of drug, an aromatase inhibitor, CDK4/6 inhibitor in breast cancer, or some of these other drugs, PARP inhibitors in ovarian cancer. These are the kind of things that we see a really bright future. I'm with Daisy on this, that it's a pretty exciting space to be in.
Dr. Barakat, you and I, well, first of all, you're currently leading all cancer services and research at Northwell Health, and you serve as professor of obstetrics and gynecology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Your card must be very crowded there. But Dr. Barakat, you and I were talking, and all these potential tools for early diagnosis may be a mixed blessing, right?
Yeah, no, I think, well, first of all, I would have to agree with Daisy. I think that the use of AI in imaging, it's going to really help the radiologist. And I like the term you use, co-pilot. I'm married to a pilot. She's a radiologist, and I would like her to work for a few more years. But I think ultimately it's really designed just to avoid errors, to make sure that we're not missing things. There are false negative mammograms. There is clearly misreading of pathology. So I think that the key that we have to focus on with artificial intelligence is just providing those backup systems. But I think the role of AI is a lot more than that. And I can tell you that we have a very bright young investigator, Dan King, in our healthcare system, who just received a $500,000 innovation award. And he developed an AI algorithm to look at scans that were performed for a multitude of reasons. And images, often the reports say that there's a small cyst, or there's this finding or that finding, and it may get overlooked or it may get ignored. But he's developed an algorithm where we can predict if some of these early findings are predictive of pancreatic cancer. And using that now, we have detected over 20 pancreatic cancers that may have been ignored or may have been noticed later on, and we've reduced the amount of time that it takes to get those patients seen in half. So I think that AI can be a very powerful helper. The other place that we're looking at AI to help us with is clinical trials matching. In cancer, the most effective treatment for cancer patients are novel therapeutics, cancer clinical trials. Only 3% of patients in the US go on to cancer clinical trials. We need that to be much higher. The problem is that it's often the same group of patients who have access to specialized centers.
So how does AI enter into expanding clinical trials for more people, and it's of course to get more diversity in clinical trials?
It shows you by mining the patient's chart and the electronic healthcare records, it shows you which patients might be eligible for. But it's not enough just to know who's eligible. You then have to navigate those patients to those clinical trials.
And there's so much misinformation about clinical trials, and people think they're going to get no drug, or they're going to get a placebo, and they'd rather have the old 5-FU and leucovorin that's been around since the 1950s for colon cancer than try something else or run the risk of not having any drug. So people just don't understand how clinical trials even work.
Right, the expression guinea pig is used a lot, but really we know that the best outcomes in cancer come with clinical trials. Also, AI can help predict side effects of some of these treatments. Who will get the side effects. 30% of patients might get one form of side effects, 70% won't. So we know who will get them, then we can proactively try to mitigate those.
That would help me with my aromatase inhibitors, which are driving me crazy. Anybody have any advice about that? See me after this panel. But can we talk about the day-to-day patient? Let's say I go to a doctor. How is AI actually going to change my doctor-patient experience?
Well, I think that it's in its infancy. But I think there's so much data coming out, and I can speak to cancer. Cancer is so complicated. There are algorithms, there are treatment paradigms that are changing constantly. And I think physicians rely on guidelines like the NCCN guidelines that are comprehensive guidelines so that we say, well, if you have this cancer at this stage, this is how you need to be treated. AI will help us in streamlining that so that if you're seeing a patient with a specific diagnosis at a specific stage with specific comorbid medical conditions, it'll help guide you as to what the most effective treatment is for that patient. Because we have to remember, we sometimes confabulate the term precision medicine, where we're looking for mutations, and personalized medicine. Personalized medicine is all the other socioeconomic factors surrounding a patient, and what will benefit that patient based on their race, their ethnicity, their socioeconomic status. I think that's where AI is really going to help us in predicting who will respond to certain treatments and how they should be treated in a much more scientific manner than us just relying on the experience that we've had for the last 20 years.
But what about health inequities? I mean, health disparities. How do you see, it really upset me. I was diagnosed with breast cancer about a year ago, and I learned that Black women have a 40% higher mortality rate. They are often diagnosed later. They tend to have denser breasts, so their cancers can be more aggressive. All these things, and it really upset me that so many people don't have access to the kind of care I was lucky enough to get. So, Daisy, how do you see this changing the equation for the terrible inequities, unconscionable inequities that exist in our healthcare system today?
Of course. I think it all comes back to data. Healthcare produces more data than any other industry, and we need to be learning from it so we can catch cancer early in populations that aren't getting access to these screenings today. And in our system today, data is so siloed, and it makes it very hard to leverage machine learning for everything it could do. And really, cancer is a great example of this. As you were saying, in an ideal world, every single cancer patient is informing the next cancer patient's journey. In reality today, we only have 3% of people in clinical trials, as Dr. Barakat mentioned, and that 3% is not equitable. It tends to be people who have access to amazing healthcare with doctors who can think of these clinical trials. And so for 97% of cancer patients, they're learning a lot, their doctor's learning a lot, maybe their hospital is having some broader learning, but the broader oncology community is not advancing because of that. And so the question becomes, what do we need to have a self-learning healthcare system that is constantly improving? And the answer is probably regulatory, legislative movement incentives for data interoperability, so all the systems can speak to each other, and incentives for HIPAA-compliant data sharing.
So when you think about the Biden moonshot, I know that he just relaunched it in February of 2022 with the goal of reducing the death rate from cancer by at least 50% over the next 25 years. Is this a case of easier said than done? What are some of the real challenges for the administration, or any administration, God knows who is going to be running this country, but to actually address this issue?
Funding, and funding. We just had a meeting this past week of the Association of American Cancer Institutes, and the director of the National Cancer Institute informed us that all NCI cancer centers would be taking a 6.5% pay reduction in fiscal year 2025. The other thing you have to remember is the 2023 Cancer Moonshot was funded by the previous funds from President Obama and Vice President Biden. Currently in 2024 budget, there is no funding for the Cancer Moonshot. The Senate bill did include significant funding for it. The House bill did not, but it's not part of the NCI budget, and it's something that all of us, by pressuring our legislators, have to push for, because we cannot make advances in cancer until we increase the amount of research we do and fund the NCI and fund clinical trials and research, et cetera.
And Andy, after funding, there's the problem of technology
Yeah.
getting way ahead of ethics, right?
Yeah.
So how can the government, differentiate good technology from bad technology, or what role can the government play?
Yeah, it's a great question, and I think every hospital and health system right now is struggling with this. I was at a meeting 2 or 3 weeks ago with all the major, chief medical informatics officers of all the major health systems in the country, and everybody's trying to figure this out, right? How do we pick out real AI technologies? Because right now it's hot. We've talked about this. We've been working on AI for 5 years, but every single startup that's popping up out of everywhere that claims they have an algorithm or a model that does something, or it actually just pings ChatGPT and then it comes back to you as something different and they call it something different. This is a very difficult time for health systems and hospitals to try to figure out what's real. What do I use that's going to make a real clinical benefit? And the biggest challenge in AI is the machine learning scientists in the room will attest. The best analogy I can give is that a lot of AI is developed. It's like teaching your teenage kid to drive in a parking lot that's got nothing in it, flat, and is 2 miles by 2 miles wide, right? My son can drive around, no problem, doesn't hit anything. And then the next day you take that car out on the highway, right out of here, right here on the FDR. And the first thing you do is crash, right? And because it's not generalizable. You can make AI models that are trained on 10 patients, 20 patients, 50 patients, but they don't work across populations, right? They're not the things that work in certain areas of the country may not work in other areas of the country. They're certainly not gonna work in China. They're certainly not gonna work in sub-Saharan Africa. And so how do we ensure that the data sets that are being used to train these models are going to provide a robust and generalizable clinical grade model so that Dr. Barakat can rely on them to make decisions? And that's
how do we do that?
I think
Is
it's
it
the scariest part of what's happening right now.
or?
I hate to use the 3-letter term, FDA, but I think at this point it's necessary. And the challenge for the FDA is going to be them keeping up, right?
I was going to say they need to have AI experts embedded within the FDA.
And probably all of us in industry, and I heard Jeff at Medtronic talk about this, I think as industry leaders and those of us, and I've had these conversations with Microsoft and others, it's incumbent upon us also to work with the FDA to sort of start to begin these frameworks, and work with Northwell, and work with all the major hospital and health systems to start to understand here are really good algorithms that you can base clinical decisions on that impact patients' lives. Because in the long run, there's, someone mentioned it earlier, it was a really good point. If you use ChatGPT and it messes up your high school essay, okay, right? But if you make a clinical decision based on an AI algorithm that you give one drug versus another drug to a patient, it's potentially life-saving or life-changing, right?
I was going to say, or life-threatening.
Or life-threatening, right? And that's really the scary piece of this. So much promise is there. To me, the answer is more regulation. We're very much for the FDA. We have the only FDA-approved algorithm in this space. Continue to work with the FDA on how this looks. But you need really large data sets that are representative of the populations that you're serving. And that's really the most important thing.
I know, Daisy, you work with all these exciting startups and you see sort of the ground floor of what's happening and how AI is being used in novel ways. So can you talk about maybe some exciting developments for patients that may be happening in the near term that we'll actually see in our medical experience?
Of course. So the biggest problems in healthcare, I think it's probably hard to argue with this, are cost and access. On the cost side, the very high cost of healthcare is driven by a lot of labor shortages, extreme labor shortages. And AI is going to help us with that very soon by taking work off of humans' plates. And then every patient is going to have an amazing AI doctor and nurse in their pocket, supplementing their real doctor if they have access to one. ChatGPT wasn't trained specifically for medicine, but it is pretty good. It's better than an average person with Google. Yeah. And I think we're making a lot of very fast progress there. So I sit in this position of privilege where I get to meet with AI and technology healthcare startups all day, and I'm very optimistic about what technology and AI are going to do for human health.
how worried are you all about implicit bias in AI and kind of skewed perceptions that result from that foundational data that is rife with sexism, racism, not an underrepresentation?
Yep.
Is that something that you all think about, and how do you mitigate that?
I mean, I can answer from our perspective. Again, it goes back to the data sets you train on. I was at an AI collaborative with some thought leaders, and the idea was, can we have a nutritional label? Like, you can go to the grocery store and you can see everything that's in your SpaghettiOs, right? And what's in there, it's not great. But you should every clinician, every patient should have access to the nutritional label to an AI model. What went into that?
Right.
What data sets? For us, our FDA-approved, model was trained on 45,000 slides, 10,000 patients, and I can break down exactly the ethnicities of all those patients, and we think it's a very diverse set, and the FDA agreed. And so we're happy to show that, but I don't know that everybody's doing that, and nobody's doing that. And so if you have this model that comes out, especially these large language models that are built on, billions and billions and almost trillions of parameters, it's hard to say, hey, what was all this built on? Well, it's sort of built on the human language and everything we talk about. Well, we're not always great, right?
Yeah.
So there's implicit bias in human nature, and so these large language models are built on that, and so of course it's going to mirror a lot of that stuff, unfortunately.
In terms of clinical trials, there's an absolute bias, which I think that AI can help with. The reality is that the patients who are getting the most advanced, cutting-edge novel therapeutics are those who know how to get to the right places. And underserved and minority patients are not getting the most advanced clinical trials. And there's absolutely a difference in outcomes for those patients for that reason. A lot of it has to do with access. I can tell you that when novel therapeutics are used, take triple-negative breast cancer, one of the most dangerous forms of breast cancer. When you look at the clinical trials that are performed at specialty centers, comprehensive cancer centers, if you look at the demographics of the patients, they look very much the same. And they don't include, for the most part, underserved and minority patients. What happens with that, the bias in that, is when you take that novel agent and it's published in a journal, and tremendous results with this drug, and you try it in the real world, it doesn't work in certain populations. And it's when I was a resident, and to save time writing notes in the chart, when we listened to the lungs, we put WNL within normal limits. When it comes to clinical trials, it means we never looked. You didn't know that it wouldn't work because you never looked to see if it worked in those patients. And where AI will help us, Daisy, and to your point, is when you take big data and you look at everybody in terms of race, in terms of socioeconomic status. It's great if you can get to a clinical trial because you can afford the $50 in parking. But what if you're a single mom with 3 kids? Or what if you don't own a car? What if you have diabetes? What if you have heart disease? That's the real world. And cancer clinical trials, and the drug companies do this for certain reasons, have very strict eligibility criteria. And in certain ways, it's a very select and biased population. And what will really help us is when we open that up to everybody and learn from everybody, because there are clearly genetic reasons that certain patients do differently. I can tell you we should learn from both ways. One of the most lethal forms of brain cancer, glioblastoma, is almost unheard of in African Americans. There's a reason for that. There's a genetic reason for that. Let's learn that and apply that to other populations. So this is bidirectional. We have to learn from everyone, and until we start making sure that all of our patients have access to all of these treatments and that we understand true personalized medicine, not if you have a mutation or not, but if you have a mutation, but you also have food insecurity and you can't travel to a center to get a certain treatment, we'll never change the outcomes of the majority of patients.
But AI is just a part of that. I mean, actually, this is when human beings and not machine learning comes in, because outreach and education is absolutely, mandatory. And honestly, I've been hearing this about clinical trials for at least 15 years. So I feel like the medical community needs to do more to step up and work with community organizations to educate and have outreach with some of these patients, because AI, I mean, I just don't see it moving the needle in a significant way, not to push back on you a little bit.
No, you're spot on. And one of the things that we're the largest cancer provider in New York, and we take care of many underserved populations, and we have a very robust community outreach and engagement effort. AI will get you to who those patients are, but the key is navigation.
Right.
Because navigation is important for all cancer patients, but it's most important for underserved patients who can't navigate the system as easily as those of us with connections who know how to get there.
Real quickly in closing, because we're out of time, but I wonder if you could each just talk about what people in this room, and even journalists and average Joes like me, can do to kind of really understand. I mean, it's changing so quickly, and just to stay informed. And what would you recommend people do? I mean, is there like an AI newsletter? I mean, how do people keep up with all of this stuff?
Yep.
And what do you recommend for everyone in the room? Because it's changing science and medicine in such dramatic ways, but it's hard to keep up with.
Yeah.
I can start. My recommendation is to use AI in your daily life. It will help you very clearly understand what it's amazing at and what its limitations are. I keep Google Bard and ChatGPT, a browser, open all day, every day. I ask a million questions. I outsource a decent amount of my work. And I have learned so much from just using it. So that's my recommendation.
Yeah, I'm a Navy veteran. We had a saying, or at least the SEALs did, don't swim upstream. And this is kind
Don't what?
Don't swim upstream, right? And this is happening, right? I think I have 2 teenage kids. I'm teaching them, use ChatGPT all day long. I'll use it. Learn how to use it. Do the prompt engineering. Prompt engineering is a role that's going to be actually a big role in the future. How you work with these large language models, how you use AI. It's going to be a productivity tool. It is a tool, just like all tools that human history has seen over the world. And I think those that are going to say they're sort of freaking out about job losses and, oh my gosh, this is going to destroy the world. Like, we need to embrace it, learn how to use it, learn the limitations, and really be careful of the downsides.
I would say that I'm not sure I understand AI, so I'm not sure I have advice to guide our patients. What I can tell you, though, is we just have to make sure that when our patients get to them, that we are using AI. And I'll give you one last example. We partner with Walgreens, which really has, looking at their app, they can tell based on buying patterns they do sell cigarettes at some Walgreens in parts of the country, breath mints, Nicorette, things that might alert you to the fact that they are smokers. They put out push notifications to say, well, you might be at risk, you may benefit from
Smoking cessation programs?
and screening.
Okay, screening.
But here's the problem. We're assuming that everybody has an iPhone. And we can't assume that all of this tremendous technology is available to everyone. Yeah. So I would say my advice is let us be the best that we can be, so that we can guide you and navigate you, and let us understand the AI to get the patients to where they belong.
Well, thank you all so much. This is really exciting and fascinating and borderline scary conversation. I'm kidding. Thank you all. Appreciate it.